Hello and welcome everyone. Myself Mijanur Rahaman, and today my topic of discussion is carpal tunnel syndrome. So first of all, you can see the diagram of carpal tunnel syndrome. So this is we have already numbered. So the number one position you are seeing, that is carpal tunnel. Number two, this is carpal tunnel, and number two, which is you can see that is transverse carpal ligament, and number three, which is median nerve, and number 4, these are blood vessels, and number 5, tendons, and number 6, these are carpal bones, number 7, that is Guyon's canal there, number 8, ulnar nerve, and number 9, ulnar artery. So we have seen in the diagram that what is carpal tunnel. So this you can see, this is the carpal tunnel basically, and we have also see the boundaries and contents in the diagram part. Now we are going to discuss this, and you can see that this is the transverse section of this part of the wrist. Now introduction. Let us introduce the carpal tunnel. So first of all, what is carpal tunnel? So what is the carpal tunnel? You have to know first, na. Then what is it? The carpal tunnel is a narrow osteofibrous passage at the wrist. It serves as a conduit for structures traveling from the forearm to the hand. So it is a narrow tunnel which is of fibrous osteofibers, and this is present in the wrist, and it is a structure which helps to pass the structures which are going through this to forearm to the hand or palm. So you can see that from this position, from through the carpal tunnel, the structures are going. Okay. Now, the clinical significance of carpal tunnel. It is a key anatomical site for the median nerve entrapment leading to carpal tunnel syndrome. This is a classic example of an entrapment neuropathy. So, what is the clinical significance? It is a key anatomical site for the median nerve entrapment, and it is leading to carpal tunnel syndrome. This is a classic example of an entrapment neuropathy. So, if you have been asked a question that give me an example of entrapment neuropathy, so you can say that this is carpal tunnel syndrome. Now, boundaries of the carpal tunnel. So, what are the boundaries? A non-expansible space. This is emphasized that tunnel's boundaries are rigid, which is central to the pathophysiology of carpal tunnel syndrome. So first of all, a non-expansible space which emphasizes that the tunnel's boundaries are rigid, which is central to the pathophysiology of carpal tunnel syndrome. Now, floor and sides, the carpal arch formed by the carpal bones. So floor and the sides are formed by carpal bones. Now radial side, scaphoid tubercle and the trapezium ridge, and ulnar side, pisiform bone and the hook of the hamate. These are the carpal bones we have already know about. There are 8 carpal bones present: scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, hamate. So these are the 8 carpal bones present. From the radial side, that is scaphoid tubercle and the trapezium ridge, and ulnar side, that is pisiform bone and the hook of the hamate. Now the roof, the flexor retinaculum, a strong fibrous bond also known as transverse carpal ligament, spans the distance between the radial and ulnar body prominences, turning to the carpal tunnel arch into a tunnel. So if we summarize, first of all, a non-expansible space which emphasizes that tunnel boundaries are rigid, which is central to the pathophysiology of carpal tunnel syndrome. Now floor and sides, that is formed by the carpal bones. Now radial side, scaphoid tubercle and trapezium ridge, and ulnar side, pisiform bone and the hook of the hamate. And the roof, the flexor retinaculum, a strong fibrous bond also known as transverse carpal ligament, spans the distance between the radial and ulnar boundary prominences, turning the carpal arch into a tunnel. Now the contents of the carpal tunnel. There are 10 occupants, okay? So 10 occupants, one is nerve and other are tendons. So in case of content, we can see there are 10 structures present. So in the 10, there is one nerve present and 9 tendons. So one nerve, which is a key mnemonic to remember the structures. The nerve is median nerve. Okay. The median nerve, the most important structure in the context of carpal tunnel syndrome, it is a mixed nerve, motor and sensory. So there is a nerve present which is known as median nerve. It is an important structure in the context of carpal tunnel syndrome. It is a mixed nerve which can function as both motor and sensory. The nine tendons, all the flexor tendons, responsible for finger and thumb flexion. Flexor digitorum superficialis. There are four tendons arranged in a superficial plane. Flexor digitorum profundus. There are also four tendons located deep to the tendons. Flexor digitorum superficialis. Now flexor pollicis longus. One tendon for thumb flexion. So 9 tendons present. 4 tendons for flexor digitorum superficialis, 4 tendons for flexor digitorum profundus, and 1 tendon for flexor pollicis longus. So there are 10 occupants, 1 nerve, and 9 tendons, 1 nerve, which is median nerve. This is the most important structure in the context of carpal tunnel syndrome, and it is a mixed quality of nerve which can function as both motor and sensory. And there are also 9 tendons present. All the flexor tendons are responsible for finger and thumb flexion. So there are 4 tendons for flexor digitorum superficialis, 4 tendons for flexor digitorum profundus, and 1 tendon for flexor pollicis longus. Flexor digitorum superficialis, there are 4 tendons which are arranged in a superficial plane, and flexor digitorum profundus, 4 tendons located deep to the flexor digitorum superficialis tendons, and flexor pollicis longus, 1 tendon for thumb flexion. Now anatomy of the median nerve. So origin. The origin of the median nerve is brachial plexus C5T1 nerve root. We will discuss in the brachial plexus video about this root and the pathways. Now we want to discuss this in a very brief. Okay. Now course. It descends through the arm and the forearm and passes through the carpal tunnel, gives off to the pure palmar cutaneous branch of the forearm before the carpal tunnel. This is why sensation over the carpal tunnel, the thinner eminence palm, is often spared in carpal tunnel syndrome. Now the course, if we discuss that it descends through the arm and the forearm and passes through the carpal tunnel, gives off the palmar cutaneous branch in the forearm before the carpal tunnel. And this is why sensation over the thinner eminence of palm is often spared in carpal tunnel syndrome. Now innervation. The 3.5 fingers are supplied by the ulnar nerve. Sensory. The palmar surface of the thumb, the index finger, the middle finger, and the lateral half of the ring finger. So what are the fingers? The fingers are, in case of sensory, the palmar surface of the thumb, the index finger whole, the middle finger whole, and the lateral half of the ring finger, and also supplies the nail beds of these fingers also. The motor function, thinner muscle, you can use the mnemonic lobe. Lobe for lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. So thinner muscle, lobe we have mnemonic, and lumbricals, the lateral two, for L, O for opponens pollicis, A for abductor pollicis brevis, and F for flexor pollicis brevis. These muscles are responsible for their thumb opposition, abduction, and flexion. Now anatomical variation and related structures. So variation of the median nerve, the course of the recurrent motor branch of the thinner muscles is highly variable. It can be extra ligamentous, subligamentous, or transligamentous. Okay. And this is surgically important. Structure outside the tunnel. Ulnar nerve artery passes through Guyon's canal and medial to the carpal tunnel. Palmaris longus tendon, superficial to the carpal tunnel roof, a key surgical landmark. And synovial sheaths, the tendons and are lubricated by synovial sheaths. Inflammation of these sheaths, tenosynovitis, tenosynovitis is a common cause increased pressure within the tunnel. Now, anatomical basis of the carpal tunnel syndrome. Compression of the median nerve, increased pressure within the non-expandable tunnel, squeeze at the nerve. Sensory symptoms, the tingling, numbness, pains, and needles are direct result of the nerve ischemia and demyelination. The symptoms appear in the specific sensory distribution of the median nerve. Now, motor symptoms. The weakness and the thinner muscle wasting, atrophy in the advanced carpal tunnel syndrome are due to chronic compression of the motor branch of the median nerve. This leads to the impaired function of the thinner muscles. Why the little finger is spared? The little finger and the medial half of the ring finger are innervated by the ulnar nerve and runs outside the carpal tunnel. This is a crucial anatomical sign for diagnosis. Now, conclusion. The anatomy of the carpal tunnel, a rigid osteofibrous canal, makes it uniquely susceptible to median nerve compression. A thorough understanding of the tunnel's boundaries and contents, particularly the course and distribution of the median nerve, is the fundamental for diagnosis and the treating for carpal tunnel syndrome. And anatomical landmarks are critical for both the clinical assessment. Phalen's and Tinel signs are surgical innervation. Now, if we see the diagram again, now you can understand the structures and the anatomical position and boundaries and contents in this diagram. We have already seen the carpal tunnel in the one, then transverse carpal ligament, then median nerve, then blood vessels, then tendons, then carpal bones, and then Guyon's canal, then ulnar nerve and ulnar artery. If we recap, what is the carpal tunnel? Carpal tunnel is a narrow osteofibrous passage at the wrist. It serves as a conduit for the structures traveling from the forearm to the hand. Clinical significance, it is a key anatomical sign for the median nerve entrapment leading to carpal tunnel syndrome. This is the classic example of entrapment neuropathy. Now, boundaries of the carpal tunnel, a non-expansible space. Emphasize the tunnel's boundaries that are rigid, which are central to the pathophysiology of carpal tunnel syndrome. Now, floor and sides, the carpal arch formed by the carpal bones, radial sides, scaphoid tubercle, trapezium ridge, ulnar side, piscibum bone, and the hook of the hamate. Roof, that is the flexor retinaculum, a strong fibrous bond, also known as the transverse carpal ligament, spans the distance between the radial and ulnar bony prominences, turning the carpal arch into a tunnel. Now, contents of the carpal tunnel: 10 occupants, one nerve, one nerve, that is median nerve. The most important structure in the context of carpal tunnel syndrome, it is a mixed nerve which functions as both motor and sensory. The 9 tendons: flexor digitum superficialis, 4 tendon; flexor digitum profundus, 4 tendon; flexor pollicis longus, 1 tendon. Total 9 tendon. Now, anatomy of the median nerve: origin, brachial plexus; nerve root, C5T1. Then course we have already discussed. Then anatomical variation and related structures also we have discussed. Then anatomical basis also we have discussed. Now, in the conclusion we have also discussed. So we have completed an important topic today, that is carpal tunnel syndrome. So if you have any query or any doubt, you can comment down in the comment section. If you have any doubt, please comment down in the comment section. I will try to reply all those comments. And thank you so much for watching my videos. Also, please do like, share and subscribe to my videos, and hit the like button and do subscribe. Thank you so much for watching.